All right, hi and good afternoon. My name is Gal. I'm a resident at the Soroka University Medical Center, and our case started as a 13-year-old girl presented to the ER with abdominal pain for about 1 day. Her lab result came up negative, and she was sent to perform an ultrasound examination. The first question, with no answers offered here, is what do we see at the picture? Is it a loculated pelvic collection, hematocolpus, or ovarian cyst? So as there are no answers, or maybe there are. Anyway, the correct answer is hematocolpus, a situation in which blood is collected, or the menstrual blood is collected in the uterus and the vagina, depending upon the amount. And naturally, the next question depends, is about the etiology. So the question is, the majority of the cases are due to imperforated hymen, Mullerian duct anomaly, or vaginal stenosis. And we are jumping to the second, you can skip, and next. And again, hematocolpus, the majority of the cases are due to either one of the three. And anyway, the correct answer is imperforated hymen. That's the majority of the cases. Nevertheless, that's not what our patient had. Had this been the situation, the presentation would have ended up now. Our patient had Mullerian duct anomaly, and a couple of words about Mullerian duct anomalies. So regarding the genital organ embryogenesis, so during the first 6 weeks of the embryogenesis, both male and female fetus are actually indistinguishable, having both Mullerian and Wolffian duct. Now, just up to approximately, as I said, 6 weeks, by that time, the Mullerian inhibiting factor, which is encoded on chromosome Y, or the lack of it actually in females, will cause the regression of the Wolffian, the male ducts, along with the progression and development of the Mullerian ducts. Now, the Mullerian duct develop, they merge, or they actually migrate medially, they merge and fuse together, and at the final stage, the septum, which builds the two structures, reabsorbs to yield just one cavity. Now, before going up, the question is, with which of the following organs do MDA Mullerian duct anomalies are associated with? Is it ovaries, external genitalia, pancreas, or kidneys? Again, with which of the following organ do Mullerian duct anomalies are associated with? And the correct answer is for kidneys. Well, with a prevalence of 30 to 50% approximately, and there is quite a wide range of anomalies of the kidneys, starting from ectopia, hypoplasia, fusion, malrotation, and even agenesis. And our patient indeed lacked her left kidney, and we'll discuss about the left side in this specific patient in a minute. And she did have both her ovaries and her external genitalia intact. Now, just as a reminder to focus again about the Mullerian duct anomaly, so the Mullerian duct will eventually form the proximal 2/3 of the vagina, the cervix, the uterus, and the fallopian tube. So all these organs which are not connected to. Yep.
Do you mean that patients that have Mullerian duct anomaly do not have anomaly in ovaries or in external genitalia?
Not necessarily.
And not necessarily with kidney. But it does go
but the main
external and kidney.
The main anomaly are the kidneys. With a prevalence of up to, even in some of the researches, up to 50%.
More than external genitalia and ovaries.
Yeah.
Okay.
And again, the reason for that is different embryonic structures which they originate from.
Okay.
So having this basic knowledge, we can categorize the Mullerian duct anomalies into broad saying 3 categories. Those patients who have problem in the initial process of the production or creation of the duct itself will suffer from aplasia or hypoplasia. Those patients who have problem in the fusion of both ducts will suffer from D-delphi or bicornate uterus, and those patients who have problem in the reabsorption will probably suffer from septate or arcuate uterus. Now, dealing with obviously imaging, the next question is, which of the following is the preferred modality or preferred imaging when diagnosing a patient with Mullerian duct anomaly? Is it hysterosalpingographia, graphisory, or MRI, or a CT? Again, preferred modality when evaluating patient with Mullerian duct anomaly. And the correct answer is indeed MRI. Well, hysterosalpingography will enable to have some kind of evaluation, but it won't really have or enable us to visualize the outer contour of the uterus, whereas MRI and ultrasound, especially the 3D ultrasound, might help us with evaluating the outer contour, which will enable us to differentiate between the different subtypes of Mullerian duct anomalies. Just a word about ultrasound. The best stage to perform the examination is the later stage of the menstrual cycle. The reason for that is the hyperechoic endometrium, which will accentuate the situation. And a word about the MRI. So the most important actually are oblique coronal T2 images. And just remember that contrast material is usually reserved for other situations or assessment of incidentally discovered additional diseases, and not for the Mullerian duct anomalies. And then back to our patient. Our patient suffered from a problem in the fusion part of the development of the genital organs, and she had uterus D-delphi, a situation in which each one of the tubes will develop fully, having both uterus horns, cervix, and a vagina. And just for your opinion, is it possible that uterus D-delphi might be asymptomatic until trying to conceive? True or false? And that's again, can it be asymptomatic until trying to conceive? And as we are stuck on 7 answers, let's hop on. The correct answer is true. For those who right now answered, it might be the situation. Just one thing I'd like to mention, and that's the important stuff here. Some patients suffering from uterus D-delphi might have, or they do have, other problems associated with. One of them is actually what you can see here as the arrow, where the arrow points. They might suffer from a transverse septum. Thus, this patient will suffer, obviously, from hematocolpus. You can see it in the MRI scan of this patient. Right here, this delicate, hypo-intense line. And one thing which is worth mentioning in regarding to the renal anomaly, so the obstructed side is usually the side where you'll find the renal anomaly. And then finally, just a few take-home messages. It's a common than we think entity. Depends with many subtypes, depending upon the stage of embryogenesis where the problem occurred. It might be associated with renal anomaly, ultrasound at the later part of the menstrual cycle, MRI, oblique coronal T2 images of the uterus. No contrast material is necessary. And for both ultrasound and MR, please remember, if you evaluate the patient, go up and evaluate the kidneys. Thank you so much.